Welcome to EMS Challenge. It's a few minutes after 9. We'll get started. We're in Troy, Alabama. Thank you, Troy Fire Department, for sponsoring us. I appreciate that. We're out here, and I forgot the name of the building already. Hawkins Hall. Thank you, Hawkins Hall. We're here from 9 to 11. We'll have skill lab from 12:30 to 2:30. We got surgical airways, pit crew CPR. We're going to do an advanced airway station, and then we're going to do some mega code scenarios. The fire college is here with us, so it should be a good day. If you're in the area, come on out. So EMS Challenge, this was started this back in 2014, doing 1 day a week at a hospital in downtown Birmingham, with the goal to bring physician-led Con Ed to the pre-hospital world. So my background is EMS. 20, 30 years ago, there seemed to be physicians more involved in that, and that kind of has gone by the wayside. So my goal for this is to get more docs involved. In the Birmingham area, I have 2 fellows now. These are board certified or board eligible ER docs. They've done their med school, did their residency, and they're staying on an extra year to learn about EMS. So very excited to have that. I also now have the ER residency program sponsoring me and giving me a physician a month to learn EMS care. So the goal is to take this in the Birmingham region and hopefully push it out. I know other parts of the state have physician training programs for the ER. There's one in Mobile right now, and I hear rumor that one's coming to Dothan as well. So it'd be great to get more docs involved. So, and for you guys in person, I'm very laid back. If you have a question within reason, you can ask. I don't have money or anything, but anything else you got, ask the question, right? For your certificate, you should get a link in your chat box that you can fill out a survey, and that will get you the certificate. It'll be emailed this afternoon. If you can't find that, or you're not in person, can't do the QR code, email Alabama EMS Challenge at gmail.com by 2 today, and you'll get your Con Ed for you. So upcoming dates in August, we'll be at Rocky Ridge Fire Department in the Birmingham area. September, I think we're going to be in Livingston. October, back in Tuscaloosa at the Fire College is the plan. And then November, the state EMS conference is coming up. It'll be at Orange Beach. It's the first week of November. We will be, I think, in Porch Creek, Indian place. I probably shouldn't say that correctly. At the end of November. But for the state EMS conference, I would advise somebody from your department should be there. We haven't had a SMEC meeting in a year and a half. So the next SMEC meeting, which will be that Tuesday, should be fairly interesting. So if you have concerns, comments, questions, statements, please bring those to that meeting, right? Cool. So the EMT, so years ago when I took this, they call it basic EMT, but there's really EMT is not basic anymore. If you look at the way the healthcare is moving, people are asking more and more of the EMT. In the greater Birmingham area, we're switching to BLS, attended response, BLS, and ALS. So the EMT of the old was the helper of the medic, or maybe the guy that showed up on scene and just kind of stood back and grabbed things for people. The EMT is being called upon to do a lot of patient care now, which is both good. It's also concerning if you think about you got a 1 semester training and now you got people doing these skills, such as giving medications, all right, assessing a patient with cardiac problems, blind insertion devices. Are y'all using Biads here in Troy? Which one do y'all have? The King, yeah. So the Kings are out there. There are LMAs, all kind of brands. I'm an iGel person. I don't sell them. I'll show you some today. But those are pretty advanced devices that we're getting these guys that have 1 semester training to use. Nobody does mouth to mouth, or mouth to mask anymore. If you do, raise your hand. And I'm going to make sure we get you screened for mental issues. Put your hand down, sir. I meant at work. That's what I meant. Okay. Airway management. One of the things that people die from is a lack of airway management. So we're putting a lot of responsibilities on these EMTs. They're meant to run CPR codes, CPR or run codes. In the hospital, if someone goes into cardiac arrest, the docs don't do anything until they get one of the attendings, right? So they have to get a supervising physician to help oversee them doing CPR and chest compressions and intubations and AED use. In the field, where the EMTs do this without any supervision. So it's a lot of responsibility out there. And I say that because for the folks that are EMTs, thanks for what you're doing. I appreciate it. For the folks that are medics, you got to help train these guys, okay? Remember, EMT training is 236 hours, I think, classroom, and it's 48 hours of clinical. And then they'll let go. A lot of folks don't get a big orientation. So we need the medics to step up and help train these guys and that y'all do the skills that you need to learn how to do. So enough preaching on the EMT. One of the biggest things that EMTs are being called upon to do now these days is patient assessment. And that's the most complicated part we do, right? Whether you're an EMT, whether you're a medic, whether you're a physician. So when you think about history or patient assessment, when you get in histories, I think about things I call STMs, stuff that matters, right? So the purpose of asking patients questions or history is to risk stratify them, to figure out, are they sick or not sick? Do they have a risk, a potential to be ill, right? So for coronary syndrome, if somebody's having chest pain, things that I think about asking them, have you ever had this pain before? If they say yes, you say, well, what was going on then? If they say I was having a heart attack last time, in your mind, you should start thinking, okay, this person is now a high-risk patient. So now maybe I'll call for someone else to help me over here. Somebody's getting vital signs. Somebody's looking up on the monitor. I'm getting a 12 lead. I'm getting a more detailed history, getting allergies, things like that, versus the 20-year-old was having chest pain. And last time they had chest pain, it was anxiety. In my mind, that puts them in a lower risk category. Does that make sense? So all the questions we ask, all the history things we ask are to risk stratify. I don't care if they're on a cholesterol pill or take a vitamin D or their grandmother had some kind of health problem. I'm asking questions to determine, do I think they're going to be sick or not sick? And if it makes them seem more sick in my mind, I move faster with them. For example, like shortness of breath. If I had a 16-year-old that was short of breath, well, let's say we got a college kid out here playing soccer, you're dispatched to, and their complaint is asthma. You show up on scene, you got a 20-something-year-old female, shortness of breath. Doesn't sound super scary, right? So you go, you start your assessment, you got your ABCs, you're getting your vital signs, you're looking at respiratory rate and work of breathing, you're assessing them. The questions I'd ask them is, okay, so you say you have asthma, have you ever been admitted to the hospital with that? If they say yes, that lets you know that they actually have true asthma. It's not exercise-induced asthma. They're at higher risk for a bad outcome because they have real underlying disease. The next question I ask them then is, okay, with this asthma, have you ever been admitted to the hospital and put in intensive care? If they say yes to that, that means they're one of the 10% of people who have asthma who have very bad disease. These folks can decompensate pretty quickly. If you've ever been admitted to intensive care or intubated for asthma, the risk of that happening again in your life is about 50%. So that makes me get a little bit more nervous. That person, I'm not going to take a longer history. I'm not going to sit back and watch them for a few minutes. That person, I'm going to start my treatment as I'm asking those questions because now I'm concerned that they could decompensate pretty quick. It puts them in a higher category for me, okay? Does that make sense? All right, my caffeine titer is fairly low, so if I start saying weird things, make a face at me so I know. Altered mental status, questions that matter. If I show up on scene and I got a 60-year-old male that normally per family is a little bit confused and altered, my first thought would be maybe he's got dementia. So I'm not really excited now, right? Got an old guy with dementia, and that's what I'm called out for. All right. But then they say, okay, well, he's also a diabetic. So now my mind's going, okay, I need to get a glucose in this guy pretty quick to see if it's low so I can fix this. All right. What if they said that I got an old guy that's a little bit altered, that he falls a lot, and now he's on blood thinners? What do you think about? What are the concerns for an old guy on blood thinners that's confused and falls a lot? A bleed, yeah, a head bleed. So this is not rocket surgery, right? As they say, right? So, that makes me get a little bit more concerned about this old guy. If it's an old person with dementia that's a little bit confused, I'm still going to do the same ABCs, my assessment. I'm going to ask the appropriate questions. But when I get the history, I got an old guy with underlying dementia that's also anticoagulated. Those guys are a big risk for head bleeds, and people die from that. So now I'll move a little bit faster, okay? I'm going to walk with vigor, all right? I'm going to make sure my history and my exam's pretty complete. And I'm going to start moving to the hospital a little bit sooner. Does that make sense? So all these questions are risk stratifying people to determine are they sick or not sick in my mind and how fast I approach them, okay? And the other phrase I like is don't forget the underlying physiology, right? For example, had a lady yesterday at triage. We have a UAB. We're lucky enough that we have staff. We put a doc out at triage now, so we can kind of screen these patients, right? Had a lady that came in. She said she was having an allergic reaction. She had slurred speech, and her tongue was big and swollen, all right? So she had angioedema. So you think about causes of that would be allergic reaction versus maybe it's a blood pressure medicine like an ACE inhibitor or something, but definitely it's concerning for an airway issue. So this lady, she was breathing about 20 times a minute. She had no stridor. She was alert. She had no rash. She had no wheezing, all right? But she has a history of this allergic reaction of tongue swelling. So for her, I'm going to go ahead and I'm going to get an IV. I'm going to get her sit her upright. I start some racemic epinephrine. There's no risk to that drug, okay? And the nurses were asking, can we give her some IM epi? Where her blood pressure was like 190/90. She was not tachycardic, not hypoxic. She had no rash. She was not hypotensive, so it wasn't anaphylaxis. And I got like a 60-year-old girl that's already hypertensive. Is IM epi a good idea for her? Probably not. There's a risk to that drug, right? There's a risk and a benefit to epi. So that risk is not too good, right? So I did not give her epi. She got Benadryl and steroids. She got repeat assessment. Luckily, she got better and didn't have to get an airway from us. But you got to think about things when you're giving a medicine. There's a risk and a benefit to any drug you give. Benadryl. Does Benadryl have any bad side effects for people? Anybody know? Anybody care? Nobody cares? Good. I like y'all. This is great. Tough crowd. Sweet. So hypersensitive. Yeah. What do you give somebody if they're allergic to Benadryl? You're screwed, right? Yeah. It's a hug, right? Yeah. So Benadryl, there's a couple things. Benadryl is relatively safe for most people. If I got somebody with a rash, with wheezing or tongue swelling, yeah, they get Benadryl, right? Because there's a limited risk to that. But there are some risks. Benadryl is an old school antipsychotic medication. It can prolong the QT. So if you have somebody who has a long QT on an EKG and you give them Benadryl, there's a risk they go into torsades. So Benadryl has a risk. If you give IV Benadryl to a kid less than 3 months of age, that Benadryl will cross the blood-brain barrier and they can actually get altered and quit breathing on you. So that's poor form too. Old people or mature people, can't say old anymore. Mature people, the 70-year-old guy with prostate problems, you give him Benadryl, he may get fluid retention and not be able to pee for 2 or 3 days. Now, we don't really care in the pre-hospital world or the ER about that, but the patient would be mad at you later on. But there's a risk and benefit to every drug, and you got to understand that. Whether you're an EMT, an advanced, or a medic, any drug you give, you got to realize there's a risk and a benefit, and you got to understand those. So for the EMT, basic airway management skills, again, I don't think they're so basic. There's nasal trumpets, there are OPAs. I got some new OPAs I'll show you, or nasal airways I'll show you later that have an O2 delivery source. You can even do capnography through them as well. It's great for passive oxygenation and cardiac arrest. The King airway, do y'all like the Kings? Yes? Yeah, it's quick, it's pretty simple. We used Kings for a long time in the ER. We're kind of moving away from them. There's some pretty good studies that big freaking balloon may inhibit cerebral perfusion with CPR. Okay, they're not super convincing, but it's there. But the King is a reasonable airway. If one, if it's a difficult airway, you can't get them intubated on first pass, or two, if you're an advanced or an EMT, King works pretty good. The iGel, I think the iGel is just redneck proof. It's easy to use. There's no balloon to inflate. We'll play with these this afternoon. It basically, you shove this gently in the mouth hole. It covers the trachea and you can ventilate. This stuff has a gel material that when it gets warm, it kind of sucks up to the trachea and works pretty good. Like I said, fairly idiot proof. The only mistakes I've seen with these, you can put them in backwards or upside down, but you really figure that out pretty quick when you do it. Trust me from personal experiences. The other issue with those is I've seen folks with tongue rings, right? And you slide that thing in there and it kind of lacerates the gel. But those are things you can pick up on your primary assessment. Let's see if this video will show up. Oh, there we go. I'm not sure if the sound's going to come out. If it does, I apologize to the folks in the room. So you can lubricate with some KY jelly. However, where I work, most folks have vomit in their mouth and it's pre-lubed, right? That slides in, you get a little push in the posterior pharynx and it finishes the way on down. Works pretty easy. You confirm placement with this, just like you would an ET tube. You need to assess breath sounds, and then you need to waveform capnography. So that means if EMTs can use this, they got to understand capnography. We've opened up Pandora's box, right? So you got to understand capnography. If you don't give waveform capnography with a blind insertion device, the King or the iGel, it's not in the right hole. It's not working, okay? Better move on. Who knows what next YouTube video is going to show up. And again, capnography is very important, and this goes back to the guys at the station level. Make sure you're pulling this thing out, talking to your EMTs about it, working with them so they understand what the waveform means, all right? And the reasons you don't get a waveform. And the main reason you don't get a waveform is the tube is not in the right place and you're not ventilating, all right? And putting a king in or an I-gel in and no waveform capnography probably means something is not working right. Pull it out, put an OPA in, use a BVM. Are y'all using passive oxygenation down here on your cardiac arrest? Are y'all putting like a nasal cannula on them for high flow O2 as you bag them or anything? Yes, no, no comments? Sometimes. Okay, we'll talk about that in the skills lab. I think it's a pretty easy thing to do. So that way, even if you had the person who's 4'6", 400 pounds, that's just hard to bag, right? And we see those folks in Alabama. If you have nasal cannula on flush O2, or you have a nasal trumpet in with a O2 cannula, O2 tubing shoved in there on high flow, if nothing else, you're giving them oxygen. And then even if you just breathe 2 or 3 times a minute, that's better than not having oxygen and a few ventilations. But we'll play with that this afternoon. BiPAP was added to the scope of practice for EMTs so they can do Cpap and Bipap. So Cpap is continuous positive airway pressure, and you guys probably use that a lot on folks, right? For BiPAP, instead of having just one number, like a 15, you get 2 numbers. So you get a 15 over a 5 or a 20 over 10. So that way when they breathe in, they get extra force. And when they breathe out, you still have some force there to keep the airways open. To do BiPAP, you usually got to have a ventilator. Those are pretty expensive. I know some places are going to that. If you ever go to advanced practice, you'll have a ventilator. And this is a pretty easy skill that EMTs can use. So BiPAP is really good for flash pulmonary edema, congestive heart failure. The guy that you show up on scene, he's sitting there, he's leaning off the side of the bed, he's pouring sweat, he's breathing 40 times a minute, he's hypoxic. When you listen to him, you hear it like, Lay Lake in the back of his lungs, right? A lot of fluid back there. Most of these folks are pretty hypertensive. So when I think about treating a CHF or flash pulmonary edema, I like the mnemonic LMNOP. There are only 2 mnemonics I like. I like the ABCs. I can remember those from a long time ago, right? And then LMNOP is the other one. So if I got a guy, flash pulmonary edema, his lungs are full of blood, fluid, which is blood, right? Blood pressure is 220 over 120, all right? I start with the P and I work my way up, and this stands for positioning or pressure. So they sit them straight up. If they're not already sitting straight up, get one of the big firemen to get behind them, stand behind them, sit them way up, okay? That's a good way to also put that Cpap over there or the BVM to ventilate them, but keep the head of the bed elevated. If you lay them flat, what happens to them? They drown and they die, right? You can't do that. When you lay somebody flat, all this fluid layers out, they become hypoxic, and they will die in a couple of minutes. Sit them up, okay? If you're doing advanced practice stuff and you have to intubate them, they stay upright to intubate them as well. So the P is position and pressure. So sit them way up tall, Cpap or BiPAP. If you don't have that, if you got them sitting up, face mask, maybe a nasal trumpet, and pressure with the ambu bag, assist their ventilations. Obviously, they get high flow O2, whether you're doing a nasal cannula under the Cpap, and then your Cpap hooked up to the wall unit, all right? Nitro, what is nitro going to do for somebody in flash pulmonary edema? What's it? Yeah, right. So it dilates these vessels, right? All right. And so it decreases blood return to the heart. So now the heart can pump the blood that's stuck in the lungs out again. What does it do to the blood pressure? Drops it. So that makes the heart work a whole lot better. So if I take the blood pressure from 220 over 120 down to 190 over 100 even, the heart works better, you get that fluid out. So you decrease the blood pressure, the heart works better, gets this fluid out, decrease preload, less blood going to the heart, they breathe better, and you can use it by this time. So for years and years, we'd have people that were on dialysis, had no kidneys, right? They miss dialysis for a couple of days. They come in, they're full of fluid. They get intubated. They go to the ICU. We dialyze them off. They get 5 days in the hospital, have bad outcomes, cost $40,000 at least. We don't have ICU beds. Now what we're doing with these folks is they show up, we're sitting them upright, putting them on BiPAP or Cpap. We don't have BiPAP. Popping a couple of nitros under the tongue, and we can use them, turn them around in like 30 minutes, and now they can go to a regular dialysis unit and go home the same day. So the point of that is Cpap, BiPAP saves lives. It is a low-risk procedure, okay, and it saves lives. Other things you can do as a medic, you can give them some morphine. What does morphine do for this person? relaxes them, right? They go from I can't breathe, I feel like I'm fixing to die, to like, hey, I can't breathe, I feel like I'm fixing to die, and I don't care, right? So they chillax a little bit. Morphine's also a dirty narcotic. When you give morphine, what happens to the blood pressure? It drops. Yeah, you get a histamine response. So it lowers the blood pressure. So it actually helps the blood pressure and makes them breathe better. Lasix, you can use Lasix. Lasix takes a couple of hours to work. In the hospital, we got to give a dose of Lasix to these people, or we can't bill Medicaid, Medicare for heart failure, right? So we always give Lasix. In the field, I'm not a big fan of that because most of the time people who have flash pulmonary edema, their volume up, but the problem is the volume is in their lungs, okay? And if we do the first three things, we can get that volume out and they're fine. Plus, if you give somebody a big slug of Lasix at their house, what are they gonna do between their house and the hospital in the back of your ambulance? They're gonna pee, yeah, right. So I try to avoid pee and poop in the ambulance. Personal opinion, you can do what you want. With COVID though, be advised, CPAP is one of those procedures that you can be chunking a lot of respiratory droplets. So if you're going to BiPAP anybody, make sure you got your goggles and N95 on. The state also still says you got to wear a protective clothing, a gown, a turnout gear or something, and just change after that. I won't ask who got the COVID vaccine and what y'all thoughts are on COVID, so we'll skip that part.
Hey, Doc.
Yes, sir.
Hey, what about the airway filters? People using the airway filters?
Yes. So yeah, those are fairly cheap. Do y'all have the filters for your intubated patients down here yet? Yeah, so those are pretty easy to use. So airway filter on the CPAP or BiPAP, you could put an airway filter on your ambu bag if you wanted to. Obviously, you're still going to get chunks of things going out the side. I think if you have someone intubated and then you put an airway filter on them, then the risk of getting influenza or COVID is almost nil because now you've stopped all the droplets from going. Pretty easy to use stuff. So filters are out there now. All right, let's talk about 12 leads. So a lot of people think 12 leads are super complicated. I would argue that a 12 lead is a screening tool. Now I know in medic school, y'all learned about vectors, right? I'm not gonna teach you vectors. I don't learn the vectors, but every year or so I go back and I relearn that stuff so I can talk to the docs about it. My point though is 12 leads can be fairly simple, easy to understand, and you can pick up a lot of madness and save your patients' lives. So my approach is pretty easy. I look at the rhythm and I say, is the rate too fast? Is it too slow, or is it okay-ish? And I use rates of 50 to 150. So rates between 50 and 150, I call okay-ish. Rates greater than 150, I like what American Heart does. I say, is it wide or narrow complex, regular, irregular, right? For rates that are slow, rates less than 50, I think about three things that cause it. I think about drugs, electrolytes, or ischemia. Now, obviously, lots of things can make you get bradycardic. If I got a 6-month-old who's got a RSV, a fever, you show up on scene, they're blue, and their heart rate is 70, then 60, then 40. What's going on with that kid? They're not breathing, right? They're hypoxic. That's the problem. So other things cause bradycardia, but you pick that up in your primary exam. You should pick that up by looking at the patient and doing a quick survey of what's going on, right? The guy that's 20 and he's shot in the gut out here on the strip, right? And you're talking to him and his heart rate's 160, and now he's diaphoretic and his heart rate's 150, 130, 90, 70. What's going on with him? He's bleeding out. Again, other things cause bradycardia. These three things, though, you can't pick up by looking at them. These things you got to kind of think about and ask about it. So drugs, so beta blockers, calcium channel blockers. I would say 60% of Alabamians are on these medications for blood pressure problems or AFib. You get an older person who's on a blood pressure medicine, and now they get a GI bug, they vomit, they get diarrhea. The body can't clear this drug, and they will get bradycardic from it. And you got to be able to figure that out and how to treat that. Electrolytes. One electrolyte jacks up the heart and makes you get a slow, wide rhythm and will kill people. What electrolyte problem is that? It's the only one we teach people. Somebody said it. I heard it in my potassium. Yeah. So potassium. So high potassium levels make you have a slow, wide rhythm. If you don't recognize that and think about that and treat it, somebody's going to die. What drug do you give somebody that's got a heart rate of 30 with a wide complex QRS and they got a big dialysis graft on their arm? What's the first drug you're going to give them besides a hug? That's not a drug. That's just good emotions, right? Epinephrine? Say no. No. Good. Yeah. What do y'all think? This is a shy crowd, man. This is not like firemen. Yeah. So I think calcium, right? So calcium will fix hyperkalemia. There's another drug you can give them if you can't get IV access. So they got graft in the arm. You can't find an IV. They're altered, slow heart rate. What else could you give them if you think the hyperkalemic? You put it in a little thing, squirt it in there, put a mask on it, put it on their face, and you crank it up. Albuterol, praise God. Thank you for saying that. I heard it. I don't know who said it, but somebody over there said it. So albuterol is great. Yeah, albuterol we think about for asthma, but albuterol actually lowers your potassium levels. So you can take somebody that has got a slow, wide rhythm, they're a dialysis patient, and you know the potassium is high. You put the albuterol in there, you crank it up, and you can watch the EKG change. The rate increases, QRS complex gets narrow, you're high-fiving your partner, you're smiling, then you turn the albuterol off, and 5 minutes later it gets wide again. So it's a temporary fix, but it buys you time on people you can't get IV access on. Great drug. What's the dose of albuterol? Anybody know? Oh, I like you. Yes. All you got. Yeah. So the dose is like 20 milligrams, man. So that's a big freaking dose. So that's what, 4 your little pre-made dual nebs or albuterol vials you got. Okay. If you're using the old-fashioned dropper, it's like 20 drops. Okay. So they get all you have. Very good. I like that. And then ischemia. So heart attacks can cause bradycardia as well. And y'all should better pick that up on your 12 lead. I say the more scary rhythms are the ones that are okayish. When the rate's between 50 and 150, now you got to determine, is it scary or not scary? And that's where you got to understand 12 leads at. So you don't want to miss things. So when I think about EKGs, I'm gonna look at this one. I say, is this rate too fast, too slow, or okay? I say the rate's okayish, right? So have a way to calculate it. You can trust the monitor on some things. It's pretty good with these numbers. If I got a 12 lead on somebody, I'm gonna be reaching over, touching the pulse as well. I'll make sure they got a good radial pulse. I can get skin temperature, right? Are they warm, are they dry? All right. I can also say, is it regular or irregular? But I look up here and I start counting boxes, and I realize that rate's between 70 to 80, so 73 is reasonable. The next thing I'm gonna do is I'm gonna start looking for injury patterns. I'm gonna look at leads 1, AVL, and 5 and 6. Those are my lateral leads, and I'm looking for ST elevation. So is there a STEMI or not a STEMI? So big ST elevation. The next place I'll look is I'll lead 2, 3, and AVF. Those are my inferior leads, same thing. Then I'm gonna look V1 through V4. These are your septal or anterior. This is the big portion of the heart. Run right down the middle and the left side, the pumping action of the heart, right? So elevation is a big STEMI. Or if you got depression, this is a posterior MI. So you see on some of these EMS blogs talking about doing a backside EKG or posterior EKG. That's all cool and stuff. I don't do them because if I see ST depression on V1 through V4, I'm assuming the backside of the heart is jacked up. And if the backside of the heart is jacked up, these folks are at a high risk to decompensate and die. So I'm not going to do another EKG to prove this. This guy is going to see a cardiologist and go to the cath lab no matter what. So if the cardiologist wants to do a fancy EKG on the backside, he can do it. But I'm going to manage this patient and assume they're having a STEMI. The last place I look is lead AVR. So AVR, you should, if you're up in 1, you should be down in AVR. That tells me my leads are on the patient correctly. The next thing I look for is AVR. If you got elevation in AVR alone, and I got depression anywhere else, laterally, such as 1 in AVL, or 5 and 6, or inferiorly, that's a big left main occlusion. Is probably a STEMI as well. In 2013, American Heart kind of changed some of the guidelines. So well, you say the AVR was only good to say if you're up in 1, you should be down in AVR. But in reality, elevation in AVR should make you uncomfortable and make you think in the right patient, they're having a STEMI. And I can tell you right now, this 12 lead machine is not going to pick that up. All right. So after I go through this, then I'm going to go and I'm going to look at my intervals. So my PR interval, right? I'm going to look at my PR interval, my QT interval. QT should be half that R to R. So from there to there should be half of that. If that's way too long, that tells me a couple things. One, if this patient was passing out or having seizures, they probably weren't passing out and having seizures. They're having runs of a dysrhythmia, torsades. 2, that tells me I got to be careful when I give certain drugs. We've already mentioned Benadryl. What's another drug we give every day in the field that can prolong the QT? Anybody know? Zofran, yes, sir. So Zofran is a benign drug, doesn't hurt anybody, and unless you have a long QT. I've seen folks up in the cardiac care unit with a long QT get Zofran, and it's pretty cool. They go into torsades. You get to do CPR, you get to shock them, give them magnesium, but they don't appreciate it as much as I do, right? So be careful. So QT. The last thing you want to look at is the QRS, right? And I usually look in V1 for the QRS because that's going to tell me if that's wide, greater than 3 boxes, either got a right bundle or a left bundle branch block, and that's going to jack up how I interpret this, whether they're having a STEMI or not. And that's a class for a different day. I just wanted to mention that. But with left bundles, you got to determine, all right, I got a wide QRS. Is this guy having a big freaking STEMI or not? And there's something that we can use called Carbosis criteria to kind of calculate that. We've done this a couple of times. It's on our YouTube channel. And then I usually touch this about every 2 or 3 months as well. Scarbosa. Hey, no worries. Welcome. Come on in. This is a right bundle branch block. Again, it should make you uncomfortable. We got these big T-wave inversion ST depressions. If you see this, you should be thinking this is the STEMI equivalent. With most right bundles, that's okay. But again, that's for a different day. And we're not going to definitely not talk about vectors. The point of this is, years ago, when paramedicine started in the 70s, we learned about dysrhythmias, junctional tachycardias, heart blocks, VTAC, VFib. You got to know those. But you also got to know about 12 leads now. When paramedicine was started, if you had a big STEMI, a big heart attack, you know what we did in the hospital for you? Sir, you're having a heart attack. Hopefully you survive this, right? That was the end of it, right? We gave them aspirin. We gave them anti-dysrhythmic medicines so they don't go into VTAC or VFib, all right? But we had no intervention, all right? We started doing streptokinase, thrombolytics in the 80s and 90s, but now we can cath people. So now if you recognize a STEMI in the field, we can actually get somebody to a cath lab and they can have a big freaking STEMI that 20 years ago they would have died from or definitely been out of work, unable to do things, to where now we've had a couple of folks that are actually firefighters in the Birmingham region, had big STEMIs, been recognized, go to the cath lab, and they're back out there doing that physical job again. They're alive and able to go back to a regular life. So it's very important we understand how to do 12 leads. The other thing is we can't trust our machines. The machines do not do a good job at interpreting 12 leads. Look at this. This is a screenshot from a cardiac monitor in a hospital. And what's wrong with that screenshot? What do you say? Yeah. Can you have that blood pressure? I don't know. If I had a few beers and I took blood pressure, I might see that, right? But in real life, that's not, no. So machines will screw up things. So y'all need to be able to read 12 leads. You're not going to get good at it looking at 2 a day or 2 a week. You got to look at a lot of leads. I probably see 50 a day when I'm in the ER. They all come to one of us. All right. If I go away for a couple of weeks from the ER, I get online, I'm looking at them again. It's a skill, just like an IV or something else. Anything else, you got to practice it. There's a web page called Life in the Fast Lane that's pretty good. There's another web page called Wave Maven. It's a great resource. So, you know, I'd say on shift, if you got time or at the house, spend an hour every week or so and just burn through about 40 or 50 EKGs so you can recognize if they're sick or not sick. We've got to be able to read 12 leads, guys. Yes, sir.
Would you try to disprove a noted ischemia from your monitor? So you run your 12 lead,
Yep.
You're kind of looking, you're not sure, you look at your patient. Patient seems almost asymptomatic a little bit.
Okay.
Monitor prints out ischemia.
Right.
At any point, do you try to disprove that, or do you go with a protocol?
So I think that if it goes back to you should be able to look at that 12 lead too. So if you look at that 12 lead and it says STEMI and you're looking at it and it says that's not a STEMI, I think then you wouldn't treat it as a STEMI. However, in Alabama, the rules, right, or you put them in the STEMI system, right? So that's where you may call med control to help with that. There are some people who have a jacked up rhythm at baseline. So there are people that can have what's called benign early repole, or they can have a small aneurysm in the heart that doesn't mean it's bad. And they'll have ST elevation, look like STEMI all the time. And they could have knee pain. I can get a 12 lead and it says STEMI. I just think that If that 12 lead says STEMI, you better be sure it's not, because if you miss it, the patient can have a bad outcome. I would rather you look at that 12 lead that doesn't say STEMI and you be concerned, say that actually looks like a STEMI, and work the other way. I'd rather you overcall than undercall. Now, can't say piss. Will you make someone mad at the hospital occasionally? Yes, so be it. But you're gonna make somebody mad at the hospital no matter what you do, whether you do a good job or bad job, but you got to go home with a clear conscience, right? Yeah, so that's a tough one. So their machines will say STEMI sometimes in the hospital. For me, they'll bring me an EKG of a guy at triage, and I look at it and it says STEMI. I said, that's not a STEMI. So I'll mark through and say no STEMI, but I get up, I go see the patient, I talk to him, and if the dude's sitting there sweaty, clutching his chest, I'm probably gonna repeat an EKG and work him up for heart stuff anyway. And if he's like, yeah, my toe's been hurting me since 1964, I'm probably gonna say, have a nice day, see you next time. If they had an abnormal EKG, I would get a troponin, yes, sir. So for those that don't know, a troponin is a blood test. So for years to determine if you had a heart attack with chemicals, we had to trend different lab tests over the course of hours to days. Now there's a blood test called a troponin that is so sensitive that it pops up within 2 hours of any kind of heart damage. It's really sensitive that if I went out and I jogged around this building twice and you did a troponin test on me, mine would probably be high because I shouldn't be jogging around the building, right? So a troponin is a great way to do things. There's no risk to that test. I'm not going to give somebody radiation poisoning or cancer by doing it. So I do a lot of troponins because it's objective data to say what's going on. The other thing, you can get young people that get pericarditis, myocarditis, that have a normal EKG that you wouldn't think heart problems on. And now I can get a troponin and I say, okay, well, your troponin's normal. This is not pericarditis, not myocarditis. Or I get the troponin and it comes back super positive. Now I know we need to figure out what's going on. Do they need antibiotics or things like that? So, yes, sir.
And you're in a city or town that does not have a hospital capable of cath lab.
Right.
And you know, you validated that by 12 lead patients, obviously, going downhill.
Yes, sir.
Do you bypass your Band-Aid station and go to a facility?
Right. So that's actually the state is working on an algorithm for that right now with a statewide STEMI system. So in reality, the answer from American Heart and the cardiologist is you want EKG in recognition of STEMI to a cath lab in 90 minutes. If you can't do that, you want to get somewhere where you can give them a thrombolytic in 30 minutes.
Valuable enough to risk the twice the 90, because if we go local, we're
Right.
Give some time.
Right. So my argument will be, I would say that if you cannot get to a cath lab within 90 minutes or so, they probably need a thrombolytic. Okay. Now there's some patients we'll talk about in a few minutes that you can't give thrombolytics to. So that goes back to the medic being able to know that and screen those folks. So years ago, I was working down in Dothan and they brought a STEMI in and they had bypassed a smaller hospital. And it was like, almost 2 hours to get to me. And I'm like, why in the world did you not stop at hospital A and get a lytic to open up the vessels and then bring them to me? Oh, guy's got an aneurysm in his brain. You can't give somebody with an aneurysm in the brain a clot buster because there's a risk that they'll die. So at that point, instead of me calling that medic a name because I was tired and grumpy, I was like, thank you, sir. You just saved a life. My apologies. So it's a tough call, especially when you don't have cath lab available places.
Does that patient stand a better chance though? See, you run the risk of a 35-minute drive to a facility with a cath lab.
Yep.
Of that patient code getting around and losing anyway.
Right.
Would it have been more beneficial to see if the thrombolytic would help and let them possibly code locally?
Yeah. So my argument is I think that if you can't get to that cath lab in 90 minutes, you can. Yeah. Then you probably should start doing that. That is the answer by American cardiologists. The European model is no, they get thrombolytics. There's some places in the U.S. where actually medics are given thrombolytics. So when I worked in Tennessee, you'd have a county with a medical director that they would let the medics say, all right, 12 leads of STEMI, I'm gonna go through my checklist. I'm gonna call, hey, this is what I got. I'm gonna give them a thrombolytic. And they give Redivase. They give 1 dose of a thrombolytic. Then they start trucking toward that cath center. If it gets better, they high five each other and he gets a cath 2 hours later. If he doesn't get better, he gets a second dose of Redivase and then he goes to the cath lab. So those are system questions that probably need to be addressed with your regional med control doc, and then the state as well. The state's looking at a guideline of how to manage that so that everybody's kind of protected, because it's a tough call. It really is. Used to be, it was when they approached the door to the hospital. Now that 90 minutes starts at first patient contact and recognition. So in Birmingham, so when you get on scene, so in Birmingham, the hospitals are looking at EMS charts now, patient, on scene with patient. So you got on scene time, patient contact time to EKG should be like 5 or 10 minutes. 10 minutes is the real number. And then the clock starts when you recognize STEMI. Okay, obviously this is an arbitrary number. You know, time is muscle. The sooner you get them to cath lab, the better they're gonna be long term. But those are some of the numbers that American Heart has put out there.
This is 6 o'clock at night.
Yeah.
Count that.
No, sir. No. Now, obviously, the guy that calls you at midnight and had chest pain from 6 is gonna have a worse outcome because he's had more time. But our time starts when we know about it.
But it's still more beneficial to attempt cath lab.
Yes, sir. Yes, sir. All right, so 60-year-old fella, weak and nausea. He vomited once, a little bit sweaty. What are you gonna do with this guy? So obviously everybody gets an ABC's primary exam. We're gonna risk stratify like we talked about with the things that matter. If you look at our protocols, it talks about suspected ACS. So when you think about the classical chest pain picture, only about 25% of the people that we look at retrospectively come in having chest pain, arm pain, and flexion of their chest. So that's the classical presentation for an MI. So that tells you that 75% of the people with heart attacks don't have that. So what do they have? They have nausea, they have vomiting. It's an old person with weakness. You can have back pain, abdominal pain, shoulder pain. You can have syncope. I had a little old guy the other day that said, "Doc, every time I get up and walk, I pass out." I'm like, "Sir, that's not good." We get a 12 lead. He's got a big inferior STEMI. So he gets up, heart goes under strain, and he blocks out and he passes out. So the point is, always think about this in the high-risk population, and you know they're high risk by the questions that you ask them, like we talked about up front. So dude's blood pressure is 115/70, breathing about 18 times a minute. He's not hypoxic, heart rate's fine. So you got to determine, does he look like he's in distress? We're going to ask the questions that matter, right? You ever had this before? Any health problems, diabetes, hypertension? Ever had a heart attack? All right. Past medical history, medications, the things that matter. I ask folks, are you a diabetic? If they say yes, I say, do you take shots or pills? If they take shots, I assume they're at type 1, they're on insulin, and they're at higher risk for having bad outcomes. Now, there are some shots for type 2s out there as well, but I try to make it simple, right? Are you on blood thinners? All right, if they're on blood thinners, that tells me they either have a bad cardiac history, they've had a stroke, or they got some kind of vascular disease that has a stent in it. So I know they're high risk for heart problems. Cocaine is still the thing in the Deep South. Cocaine can cause vasospasm, make you hypertensive. You can have strokes and heart attacks, all right? And then I talk about the blue pill, right? Viagra, all right? Now, I'm not gonna ask this guy in front of his girlfriend laying on the ground at Walmart, "Hey, dude, do you take Viagra?" What's he gonna say? He's gonna say, "No, sir," right? So you gotta be polite, right? Lean down, whisper, ask those questions and tell them why. So, "Hey, man, no offense, if you do, that's fine. But if you take this medicine, I gotta know because I can give you a medicine that could kill you if you take this medicine," right? So this is this 12 lead. Too fast, too slow, or okay. If you say okay, I'm gonna pass out, right? So I say it's okay-ish rate-wise, right? I'm gonna look at injury patterns. I look at leads 1 in AVL, and now I'm sweaty, right? A little bit elevated. I look at 5 and 6. Now I'm using profanity. Very concerning, right? 2, 3 in AVF, I got reciprocal changes here, ST depression. I still look at every EKG the same way, so when I'm really tired, I don't screw something up. So now I'm gonna go look V1 through V4, and I'm super terrified. Big ST elevation, right? I go back, look at AVR and 1 are opposite. I'm gonna look at my intervals. I go over here and look at my QRS, and that QRS is not wide, it's just a big freaking STEMI going on, right? So this is a big STEMI. What part of the heart's being affected with this STEMI? Septal anterior, I would say most of it, right? Okay, so we're up laterally in here. So this is a big freaking MI. So now my guy went from, I was gonna risk stratify. Do you have hypertension, diabetes? Do I think you're having heart problems? To, I don't care what your history is. because now, welcome to the club. Now you have heart problems. So this is a big STEMI, right? So now what do we do for this guy? What are priorities of care for the student in the field? Yeah, perfect. So early 12 lead, talk to your system, determine if he's going to a cath lab, where you're going to go, have that pre-planned, all right, let them know you're coming that way. You mentioned MONA. I like MONA mnemonic as well. What does MONA stand for? I misspelled MONA. I got MONO. MONO. They get double oxygen. Dun, dun, dun. So what is the most important drug we give these folks? Aspirin, yeah. So aspirin jacks up platelets. So if they got a clot, including downstream flow, if I give them an aspirin, these platelets cannot stick together. The body's response is, I got a clot here, something's not going on. I'm gonna send cells there to fix this. Those cells stick together, the clot gets bigger. Aspirin helps prevent some of that. It doesn't fix the clot, but it makes it not get any bigger. So aspirin is very important. What patients do we not give aspirin to that have a STEMI? Kind of weird question. Yeah, so I would say if they have anaphylaxis to aspirin, they don't get aspirin from me. If they say, doc, last time I took an aspirin, I swelled up, they had to cut my throat. No aspirin for you, right? If they say I have a GI bleed, I crap blood sometimes, and they're having a STEMI, I'm still giving them an aspirin. I can give them blood at the hospital, all right? If they're having chest pain and a normal EKG or not a STEMI EKG, I won't give that person an aspirin. It's a risk stratification, right? If he's got a STEMI, that kills people quick. He gets an aspirin, right? So aspirin, what does nitro do, the N? Dilates the vessel, so it gets more bloodstream, blood flow downstream. Oxygen, even if they're not hypoxic and they're having a STEMI, I give them oxygen. American Heart says don't. I say do. And I say do because I'm not giving them supplemental oxygen. I'm giving them pre-oxygenation because these guys are high risk to go into cardiac arrest. And if you're driving this guy in, you got one medic in the back of the truck, and you don't have him on O2, and he goes into cardiac arrest, now you're screwed. You pull over, you start CPR, your buddy comes around, you bag him, put the pads on, you defibrillate. Whereas if you already have O2 on the guy and he goes into VFib, you crank the O2 up to high flow, you get passive oxygenation. If you have your pads on him, you charge and defibrillate, and you may get lucky, right? And you keep trucking down the road. So I do oxygen as a pre-oxygenation. And then morphine, we kind of talked about morphine. It dilates the vessel, improves blood supply downstream, also makes them forget they're having chest pain. What is FONA? What is the F? Fentanyl. So some people advocate using fentanyl for the chest pain. I would probably say no. It doesn't do anything to blood pressure, doesn't lower the blood pressure, doesn't vasodilate. May make them a little bit high. There's no big risk to fentanyl. So if you have it and you want to use it and your med director likes it, not a big deal. What about CONA, using ketamine for STEMIs? I'd argue no. I appreciate that, making that face. Yes, I'm not a big ketamine fan when it comes to this. You're going to increase their blood pressure, might make it work a little harder, increase their heart rate, increase oxygen demands. I'm not a big ketamine fan when it comes to STEMIs. Ketamine is a good drug for a lot of things, but probably not STEMIs.
Car wrecks, trauma patients.
Yeah.
But when you give a medical patient ketamine, you lose your patient.
Yeah.
They talk about Christmas.
Yeah. Yeah, ketamine is a pretty big dissociative, right? Yeah, I agree. The other thing with ketamine, and I got some slides on it later, is anytime you give somebody ketamine, there's a big risk for them to decompensate. So ketamine's safe in a patient that has taken no medicines. So if I got a patient that comes in and their shoulder's out, I give them ketamine, I reduce their shoulder, everything goes well. But that's not the folks we usually take care of. The people we take care of have been smoking a little weed, took some Xanax, had a few beers, maybe shot up some heroin, and now I give them ketamine. Now you got problems because you can get some pretty significant respiratory compromise. So, great. So just showing some flow. So you got a big clot there, everything moving downstream. If you don't give aspirin, you don't give blood thinners, that clot gets bigger and bigger as you go. So we were talking about lytics earlier. The state has a checklist. I'm sure every medic here has seen this checklist and you use it on every STEMI patient, right? Yeah, me too. So my statement is, with the checklist, you need to understand this information. You need to get this information on your patients. Me personally, if you write it on a glove, or a piece of tape that's taped to your leg, as long as you get this information to the physician, that's fine. Because there's some patients that we can't give lytics to. And some patients will go into cardiac arrest as you pull into the ER, and now I can't ask those questions. So I got a guy having a STEMI that's now in V-fib, was shocked 3 times, and gave an epi to. I got to decide, okay, I know he's having a STEMI. Do I give him a thrombolytic, or do I work him a few more minutes? If you've gone through this checklist and you can tell me he's got no bleeding issues, never had an aneurysm or hemorrhagic stroke, and I know it's safe, I'm probably going to give him a thrombolytic and hopefully open up that vessel, and the next shock will get him back. Versus if you say, yeah, he had spinal surgery 4 days ago, now I know I can't give him a thrombolytic because he's going to bleed into that spinal canal or his brain, and I can't give him a drug that's going to kill him, right? So now I'll be more aggressive in the way I resuscitate. So now I'll have to be thinking about antiarrhythmics, maybe change up a few things, look a little bit deeper. Does that make sense? So this information is very important. Whether you use the sheet or you don't use a sheet is up to you and your system, but the information is very important. And again, some states are using pre-hospital Retivase, which is a pre-hospital thrombolytic. So like I said, rural Tennessee is using that stuff right now. We've already talked about oxygen. There's pretty good data that high flow O2 in patients with heart attacks or strokes is bad, but it's bad if you use it for 12 or 24 hours. That's not you, that's not me. We're doing this for 30 minutes, 40 minutes, maybe up to 2 or 4 hours. There's no data that it's bad for those folks, and we know hypoxia kills people. So this is another STEMI that came in the Birmingham area. The medics were pretty good. They put him in the back of the truck. He had nasal cannula. They put the defib pads on him. Went into VFib. They put their cigarette out. The medic did, charged and defibrillated, and we got the guy back. And as he comes into the ER, he's calling my mama names and using profanity. He's not happy, but guess what? He's alive. Sweet. This is just a picture somebody sent me from the cath lab. This is a guy who had a STEMI, and you can tell they got the cath in there. The balloon is up when the ST segments look normal. The balloon is down when he's up. So they're trying to open up that clot. Inflate the balloon, crush the clot. Look, is it better? Before they put the stent in. Pretty dynamic changes, pretty cool. So dude had the STEMI, EMS did the Mona, got him in the system. He gets to me. This guy, I'm gonna draw a couple quick labs. I'm gonna get an extra IV on the guy. He should already have the pads on. He's got O2 on. I give him more anticoagulation, some heparin, and another antiplatelet drug. So we want to get his blood super duper thin. That's a medical term, super duper. You can chart that, okay? And then we decide, does he get a lytic? Does he go to the cath lab? Or do I think the dude's really jacked up and need a cabbage? If he does, we're screwed because I just gave him a bunch of blood thinners, right? So hopefully he doesn't. This is his, that EKG, this is his cath report. So in the Birmingham area, we're getting these out to the folks as much as we can. So the stimulants will come in. We'll get the feedback on them, and we'll try to get the cath report. So guy had a proximal LAD lesion. So we got dye in the vessels. You can see that right there is gone. So the whole center part of the heart and left side of the heart is jacked up, gone, no blood supply. They put a stent in, and you can see now we got blood supply going back to the rest of the heart. The sooner the better, all right? This is just a schematic I got off Google, but it kind of shows you where you think the clots or STEMI is. So AVR up is coming off the aorta, the cusp. This is right coronary. This is the LAD, the circumflex. So dude's whole middle and left side of his heart was jacked up. So in the cath lab, he became hypotensive, kind of went into cardiogenic shock because that left side of the heart wasn't working well, and now the left doesn't pump. So you can see there's this other thing in the heart as well. It's called an impella. So they go in, they put this little catheter in his heart, and it goes through the aorta into the left side of the heart, and it basically works like a vacuum, and it sucks blood out, and it improves cardiac output. So that increases the blood pressure, it gets blood return going back into the coronary arteries, and it's a support device. They keep that in for a couple of hours to a couple of days until that left side of the heart regains its function. So that way he doesn't stay in cardiogenic shock. We limit the medicines we use, works pretty good. sure y'all have heard balloon pumps work similar. A balloon pump goes into the aorta and it expands and contracts and it helps pump blood out of the heart and pumps blood back into the coronary vessels. So sometimes they use this to increase perfusion into the coronary vessels. Sometimes they use it to increase cardiac output. But that bridges the gap until the heart recovers. And God does pretty good. Lvads, y'all have many Lvads down here in this area? Most places, yeah, those guys, they used to have to be near an academic center. Now, most of the folks can go live a regular life wherever they want to go. I'll have the LVAD coordinator from UAB come do a class online for us soon. These are way too complicated for me. When they show up in the hospital, I manage them by saying, can you please page the LVAD coordinator to the ER? That's the way I take care of these people. But short version is, heart is, you got a incision in the left ventricle. So the LVAD pulls blood out of the left side of the heart. It runs it through a pump, almost like a pool pump, and it squirts it back out. And you can do left-sided or right-sided. Works pretty good. These guys, sometimes you can't feel a radial pulse. Sometimes on the EKG, it looks like they're almost in VFib, but they're talking to you. You're not sure what's going on, but that's a complicated.
Hey, Doc, we got a couple of questions have come in.
Yes, sir.
So the first one was, could you talk a little bit about the process of getting TCC to put a patient in the STEMI system when the medic sees the STEMI and the machine doesn't?
Sure.
Second one is, if we're going to load up the patient with albuterol when they're hyperkalemic, do we have to call for orders for that?
Okay.
And the third one is, can you speak to, we've been told in the past that giving one of the clot buster drugs will keep the patient from going to the cath lab. So is that true or not true? How does that affect the decision to stop or
Okay.
go to a lab?
All right. I've already forgot the first two questions. That's not good. Okay, hang on.
All right.
way too much.
So first one
So-
is STEMI system, but the machine doesn't say keep
So
STEMI.
the state says for the STEMI rules, if the EKG says STEMI, you call TCC. You're all in the STEMI system here, right? Because not yet. So it's going statewide soon. Okay. So when the system is statewide, the way it works is if the EKG says STEMI, you'll call TCC and say, this is what I got. All right. If the machine does not say STEMI, because like on a left bundle or right bundle branch block, it won't tell you there's a STEMI a lot of times, but you think it is, you call TCC and say, I have an indeterminate EKG I'd like to put in the system. And then they'll take it down and they'll hook you up to a cath lab center and you'll talk to the doc and they'll look at that EKG, you'll send that to them. My goal, at least in the Birmingham region, that's where I work, that's why I say that, guys, I'm not trying to diss anybody, is that I have a linkage between the ER doc and the cardiologist that can all get on the same text with the medics in the future and kind of relay what needs to be done. But for now, the way it would work is you call TCC, I got an EKG that's indeterminate, I want to put it in the system, they'll hook you up to a hospital that's cath lab available, you'll talk to that doctor and you determine yes in the system or no. If they say no, not a big deal, you still try to go to that cath lab hospital because it's on that doc now if he thinks different. And there have been cases where the medic's like, this is a STEMI, and the doc's over the phone like, nah, I don't think so. And they get to that hospital and it is. Okay. Again, you guys should be the experts on 12 leads. I mean, obviously the cardiologists are gonna know better, but when it comes to STEMI or no STEMI, normal, abnormal, you guys, us ER folks, we should be the guys heading the pack with that. And then if it's abnormal, then we get cards involved. And if they don't want to do something, they don't see something, it's on them. It's not on us. Okay. For the albuterol, yes, albuterol is category B for hyperkalemia. You got a call for that, but it should be an easy one to call. And my advice when you make radio calls is short and simple. The more you talk, if you're calling me, if you talk more than like 8 seconds, I'm already thinking about going fishing or something, right? So it's, hey doc, I got a patient on dialysis that's hyperkalemic, they missed dialysis. I'm gonna give them some albuterol, see you in a few minutes, thanks. And then my answer is like, sure, right? If you say, I got a 43-year-old male, he's an Auburn fan, he's been on dialysis for 6 months, you know, he likes long walks on the beach. I'm like, dude, you're an idiot. What do you want, right? So short and sweet, tell us what you want, what you really, really want, and we'll give it to you, right? That's good. That's Chief Ward's favorite song. Okay. What was the third question? Oh, the TPA or lytics. Yes, you can give you can do a rescue cath. So you can give somebody a thrombolytic and take them to cath ab an hour or two later. It's called rescue cath. So you could give Redivase, and then an hour or two later, you can go to the cath ab. I've worked at community hospitals that didn't have cath ab, where I've given TPA, like you get for strokes, or there's another one called TNK. You lyse them, and then you send them to a cardiologist, and an hour or two later, they go to the cath ab. You can do that. They will not go get a cabbage. They can't go have surgery for a while, obviously, right? But you can still get a cath done. So.
Awesome. I think that answered everything. We ready for break?
Yes, sir. We better break. I'm getting scary looks right now. So
we're going to take about 10 minutes, everybody, and time to stretch your legs and all that, and we'll be right back.
All right, guys, we'll get back. Welcome back. We're still down in Troy. I'd like to thank Troy Fire Department for sponsoring us and Chief Stevens. Really appreciate you guys coming out. I'd like to thank the Alabama Fire College as well for sponsoring us, putting us on the road. Do not do it without you guys for sure. So thanks for showing up. Appreciate your help today. And I went way too long-winded on the last hour. Sorry. So I want to talk a little bit about GI bleeds. This is something that obviously the goal of this for pre-hospital care is to recognize a sick patient versus a not sick patient, to know when to, get them up out of the house, start moving toward hospital to resuscitate them, versus when you have more time. So this is a 53-year-old male, belly pain, nausea, vomiting. Obviously, same approach. I'm going to get my ABCs while I'm getting my history. I'm asking the pertinent questions. I look at the guy. He's alert, but he's pale. His belly's kind of distended and tender. I'm laying my hand on his pulse. He's got a radial pulse that's fast. His skin's warm and dry. Questions I'm going to ask this guy with belly pain, the STMs, things that matter, are like, have you ever had this before? What was the cause of it? Any history of abdominal surgeries? Folks who have had abdominal surgery in the past are high risk for badness. They can have obstructions and things like this. Guy says he has a history of ulcers, and I drink a lot and I smoke, right? So welcome to Alabama. That's kind of funny. Medicines, like a lot of the patients we see, not about usefulness, the blue pill, the white pill, the round pill. So I go through, do you take shots or pills? Do you have diabetes? Are you on blood thinners? The important things that matter, right? But just with this guy's history that he tells us that he's got ulcers and he drinks a lot, what can we think about as far as belly pain? What could be some causes of his belly pain and vomiting? Anybody know? Anybody care? How many Alabama fans here? Raise your hand. How many Auburn fans? How many no comment fans? Yeah. Troy. Yes, Troy. That's right. Yes. Yeah. Yeah, I use Alabama or Auburn as a screening tool in Birmingham. That's what I ask people. So even if they're unresponsive, if you say roll tide, they do something. They either flip you off, they stand up and say roll tide back. And if they don't, they get a CT scan, right? Exactly. Yes, sir. So with alcohol use, things that I think about in my mind is alcohol causes liver disease. Liver disease can be bad, cause a lot of issues, bleeding disorders, things like that. We'll talk about in a second. Could be gastritis. Folks who drink a lot of alcohol, folks who are diabetics, folks have chronic health problems and take multiple medications, they're high risk for pancreatitis. That can cause belly pain and issues. Is he drunk and that's why he's vomiting? Okay. Smoking increases the risk of aneurysms, so like a AAA, that can cause belly problems. Surgical history I kind of mentioned as well. And then abdominal exam, location is fairly important to some degree. So classically, we kind of talk about right upper quadrant pain is liver or gallbladder, or maybe a kidney. Left upper quadrant, I think more gastritis, maybe stomach ulcers, maybe a pancreatitis, sometimes kidney as well. Right lower, classically, we talk about appendicitis, but it could also be in females ovarian issues. Left lower, I always think about infections like colon infections, diverticulitis. Could also be kidneys or ovarian as well. Things to think about with the abdominal exam is that intoxicated people, folks high on drugs, folks that are altered, you can't trust your exam. So you can mash in their belly and they say it doesn't hurt, it doesn't matter. I had an ectopic pregnancy the other day, and this lady who was a little bit altered, she had probably 1 liter of blood in her belly, and she still really wasn't that sore, but she had a big ectopic. But you pick it up because she's of childbearing age, she's symptomatic, and she was pregnant, right? So it's like, oh, this is probably an ectopic. But the point of that is older people, folks that are altered, intoxicated, you can't trust your belly exam on those folks. And the A or A is Alabama or Auburn. Important questions. When people talk about their nausea, the vomiting, or diarrhea, I always ask what it looks like. One, it's kind of funny to kind of hear how they describe it. And two, it's useful, right? So if somebody's throwing up bright red blood, okay, that's concerning for some kind of major arterial injury up in the belly or active upper GI bleed. If they're crapping bright red blood, that's concerning for an active bleed versus something that's digested, right? So bright red blood is bad for some kind of active bleed that could be really bad versus the darker stuff that may be kind of congealed, digested a little bit, not quite as scary, right? Sweet, I like vomit. When you think about GI bleeds, you think about their upper GI bleeds, their lower GI bleeds, and then non-specific, right? So upper GI bleeds, we usually get melena, they get, so I have a slide, I don't have that yet. They get digested blood, so if they crapping out blood, it's going to be black, it's not going to be red, black, or purple. Upper GI bleeds, you can get some coffee ground emesis they talk about, but the more concerning thing would be just bright red blood. Lower GI bleed, you get the bright red blood. The non-specific, the kind of things that bite you, it would be abdominal pain, syncope, weakness, systemic complaints, along with either the vomiting or diarrhea of the bright red blood. So back to this dude. So he's alert, he's pale, he's got a fluid wave. So when you kind of push on his belly, it's almost like it's just full of fluid there. He's a little tacky, blood pressure is soft at 80/60, breathing a little bit fast. He's set 98%, glucose is 200. And so my rule on glucose checks is I keep it simple. If the machine reads low, I can fix it. I know what the problem is, right? They get D50, right? If the machine reads high, I know what the problem is. Then maybe DKA, they got a bad endocrine problem. If it's between low and high, so if it's between, 80 and 400, I don't really care for the most part in the ER. Okay, mine's gonna be 400 after a donut, so it doesn't really matter. So low and high is what we're looking for. And then his Untitled was 24. Do y'all have access to, do y'all use nasal capnography down here? Yes, no? Yes, yeah. So I got a guy who's hypotensive, tachycardic, and blowing off CO2. So what's going on with this guy? Is he sick or not sick? Sick, right. So is he acidotic? Yeah, so he's pretty acidotic, right? So he's volume down. We know with blood pressure and heart rate. And then we know that he's got systemic issues because his N-Type-2 is 24. He's breathing fast to blow off that CO2, so he's acidotic. So pretty sick guy. Sorry, I just like the picture of vomit. So when you think about liver disease, it's pretty concerning. It's in the top 13 causes of death. Chronic liver disease is. Obviously, COVID is somewhere in there, but liver problems are pretty significant. You think about the alcohol use issues we have in the Deep South. Acute liver failure can become from overdose of Tylenol. Lots of drugs can cause this. Obviously, trauma, the guy that's got a GSW or blunt trauma to his belly. Any kind of colon or GI cancer, that cancer will end up in the liver if it's not treated and cause metastases and some issues. Chronic problems that cause liver issues, hepatitis, really big in the Deep South. Alcohol, probably the #1 killer. Other drugs, a lot of drugs jack up the liver. And then NASH. Have y'all heard of NASH? It's non-alcoholic steatoic hepatosis. Big words I can't say. Basically, it's the fatty liver. Okay, we're seeing that more and more common in the folks in the 50s or 60s with type 2 diabetes. The blood supply to the liver is two forms. It comes from the aorta. It gets arterial. Then anything, all the blood from the gut, from the stomach, the colon, the intestines, goes back to the liver. So that's why any kind of infection in the gut can get to the liver. Any kind of cancer in the gut can get to the liver as well. What the liver basically does is when it brings the blood supply back from the gut, it filters it to the liver cells and it washes away the toxins. So you can see that folks that drink a lot of alcohol, the alcohol gets to the gut, it's filtered through the liver, and then that alcohol kills these cells. They get hard, they get brittle. And these cells, in addition to filtering, they also make things. They make proteins, they make blood thin, they make the clotting proteins in the blood, and the liver starts to slowly die off. Not a good thing. So folks with liver issues, because of the fact that the liver makes clotting proteins and other issues, they're chronically anemic, so the blood counts are always low. They're also chronic bleeders. So a person with liver failure is just as high risk as a person on blood thinners for falls and injuries. High risk for head bleeds and other bleeds. Other things that with liver disease is the folks that get liver disease from alcohol use or drug use, they get brain atrophy. The brain kind of shrinks and it puts pressure on vessels in the brain. And those vessels can tear and break pretty easy from minor falls and injuries. And they tear, and now they bleed like a freaking pig because they don't have good blood clotting factors in there. So they're anemic, they bleed easily, they're malnourished, all right? A lot of issues with liver disease, a lot of issues. The other issue with liver disease is when the liver gets hard, this blood that's coming back from the gut gets backlogged. It can't go through the liver anymore because those cells are jacked up. So you get varices, you get big vessels that swell around the stomach and the colon and up in the esophagus. And you probably heard of esophageal varices. This does a couple of things. One, it puts these folks at a higher risk for bacterial infections from their gut. It causes them gastritis. If they get ulcers, they can bleed a lot worse, and they can have esophageal varices where they bleed as well. So pretty bad stuff. So portal hypertension, you see varicose veins. Because of these extra dilated veins in the gut, the fluid, the serum leaves the vessels and gets in the peritoneal cavity. So they get a big distended belly with fluid in it, with that fluid wave. So a lot of big issues with alcohol problems. So big belly, protuberant. This is ascites. It's just a clear fluid in the gut. For agencies that are moving toward using ultrasounds, and when you do a fast exam on somebody on scene to determine if they're having blood in the belly from trauma, a good way to practice to see what a positive fast looks like is find somebody with cirrhosis, because they're going to have a positive fast all the time. There's always fluid in their belly. So pretty cool stuff. But big risk, right? Bleeding risk. They get fluid shifts. So these guys are always hypovolemic. They don't have protein in their blood. So if you give them a liter of fluid, 3/4 of it leaves the blood and goes into the belly. So it takes a lot to resuscitate them. A lot of times we have to give them albumin or plasma in the hospital, and that keeps the fluid in the blood cells. Otherwise, I give them liters of fluid to resuscitate them because they're septic or dehydrated, and all the fluid goes in the belly. And that's not good, not good at all. Just a positive fast for you guys that are thinking about using ultrasounds. We're making a big push to get ultrasound training in the primary paramedic education. We're also trying to work with the fire college as well to bring ultrasounds out in the field and bring it on the road show to kind of train some of that. An ultrasound's easy to use. There's low risk. You're not going to give somebody cancer or radiation, and it gives you a lot of data. You can look for traumatic injuries in the belly. You can look for a collapsed lung. One of the fellows is working at Centerpoint last week. There's a cardiac arrest that they thought they got ROSC on. They had a big jump in capnography. Still couldn't feel the pulse. So he pulls out his ultrasound, looks at the heart, and he's like, yeah, we got good cardiac conduction. Things are going great. Let's start some pressures. And the patient actually got better. So very useful stuff. So these are varices. So this is a scope looking in somebody's throat hole, the esophagus, right? So you got these big vessels here, right? So you can imagine we got these big vessels, a lot of pressure because of the backlog there. The guy already bleeds pretty easy. If one of these pop, you're going to get almost arterial flow bleeding. So liver disease, bright red blood, vomiting, those folks can die on you pretty quick. Super sick patients. Those guys need to be at a hospital where we can do a few things for them. If you have a GI doc, they can go in with the scope and they put bands and tie off these vessels. That's really hard to do when you got blood pouring out of this though. So a lot of times what we do to these folks is symptomatic control. They get blood products. We give them a medicine called octreotide that causes those vessels in the stomach to constrict. We give them blood products. We get them intubated, and we put one of these archaic looking tubes. This is gently placed in the mouth hole, right? And it goes into the stomach. We inflate one balloon, which is in the stomach, and then we snatch this back, and that puts pressure on any vessels that are up here. And then we inflate the hot dog looking portion, in theory, puts pressure on the esophagus, and we tamponade the bleeding. with the hopes that we can give them blood products, clotting factors, something to constrict the vessels, and they get better. And then a day or so later, we deflate this and hope they can go on with the scope and stop that. But I've seen people with varices bleed out and crump and die 30 minutes. Pretty concerning. So folks with liver disease can have madness. Any kind of GI bleed is bad for them. Long-term care for liver failure issues would be, this is a splenorenal shunt. So to fix the varices, we go in surgically and we put a tube from the spleen to the renal vein. That makes the spleen get really big, but it takes the pressure off this so those varices don't get so big and they don't bleed so much. You can also do what's called a TIPS procedure. And as a surgeon, we take blood from the portal vein that goes back to the liver and run that into the vena cava, and we can kind of bypass the liver. So they still can't make clotting factors. They're still anemic, but you don't get the varices. And this preserves life a little bit longer. So liver disease is tough. That's inappropriate humor, make you stay awake. Back to the case. So we got his vital signs. He's belly's tender, vital signs are as noted. What are we going to do in the field for this guy? So we're going to, one, recognize he is sick. And I'm a big advocate that for most emergencies, medical emergencies, cardiac arrest, pulmonary edema, things like that, anaphylaxis, you stay on scene, you manage the patient. This guy's not a lot you can do for this guy. So this guy, you recognize he's sick, you get him upright, you get IV access. You're going to probably limit your fluids because it's not going to do a lot of good because everything's going to his belly, right? But you recognize he's ill so you can get to the hospital so we can start doing things to manage this guy. All right. So what if instead of throwing up bright red blood, now he's got this dark stuff instead? So now it kind of makes you think, okay, he could have varices that are leaking and then he swallows that, digests it, and he craps it out, or he vomits it back up and it's partially digested, right? Or he could have ulcers, other things, right? So he can have issues where he's got blood in his gut that gets slowly digested, it turns black, and then he either vomits it up or he craps it out. And again, with liver disease, you have ulcers. You also have those varicose veins in the gut and the stomach, and you can have pretty significant bleeding. So this guy in the hospital, he gets IV versions of Zantac. So he gets like a Prilosec, but he gets IV version. We can give him some Carafate that kind of coats the stomach. And then H2 blockers, Pepcid, Zantac as well. Then obviously he gets fluid resuscitation. A lot of times we'll give him Octreotide as well, and he gets blood products. So the question I've got in the past is if you're an advanced practice medic and you have blood products and you got this guy with known liver disease who's vomiting up blood, who's hypotensive and altered, or hypotensive and tachycardic, does he get blood products? And I would say yes. He's anemic at baseline. He needs it on an everyday basis. And now if he's crapping and throwing up blood, he needs blood now. These guys take large volumes of blood to resuscitate them. 8, 10 units, easy. That's just a scope going down looking, and you can see an ulcer in the stomach lining. It's nice and kind of healing up there, scabbed up some. But if there was a vessel that ran through there, that thing would bleed like crazy. And if you don't have clotting factors, liver patient, it'll bleed for a long time. So again, bright red blood coming out the mouth hole, you think varices. Dark blood vomiting up, you think probably an ulcer versus a varices, that he's kind of digested some blood. Purple blood out the backside, pooping, is digested blood. It could be upper or lower GI. Bright red blood coming out the backside is a lower GI bleed from diverticulitis or something. And these folks also can die pretty quick because you gotta compress that vessel, and it's hard to compress it when it's in the backside. So for you guys, we recognize they're sick, recognize this patient is critically ill. You expedite transport. TXA, can we use TXA for bleeding? Yeah, so it's category A in the state for hemorrhagic shock. You're gonna have some docs argue you should not use it for GI bleeds. There was a study done that looked at GI bleeds, and it said that if you give TXA to the majority of GI bleeds, that their mortality rate increases. But when you look at that study, it actually lumps in slow chronic GI bleeds, people with cancers, issues like that, with folks who have acute bleeds as well. I think if you just look at people who are having just the acute bleeds, TXA actually works. So the way TXA works is if you have a vessel that's torn and the body tries to clot it, the body will clot off that vessel. And then a few minutes later, the body says, okay, do I still need to use these cells to block this vessel and make it not bleed? So the body breaks down the clot just a little bit to see if it's going to leak, right? And if it starts leaking again, the body rebuilds the clot. But if you do that enough, you run out of clotting factors. And liver folks are already at that state of baseline. If you give somebody TXA, the body does not break down that clot. Once it makes a clot, it holds that clot until it wears out. So that's the benefit. So if somebody has a new varicose hemorrhage or a new rectal bleed and they're pouring blood out and we give TXA, in theory, the body should be able to clot that off and hold that clot and make them better. So long-winded version to say, if someone is unstable from a GI bleed, TXA is reasonable. Currently it's category B, so you're on the phone with the doc again. Hey doc, I got a guy that's altered, he's hypotensive, tachycardic, he's crapping blood, I'm gonna give him some TXA, I'll see you in a few minutes. The doc should say sure, right? Don't make it long. Cool. Fluid bolus, yes or no, I'd probably limit that as much as you can. Obviously, if you got a long transport, they're sick as dirt, heart rate's in the 140s, blood pressure 70, you gotta do something, but I'd be trying to get to them to a place where you can get some blood products. Talked about TXA. In the ER, what we're going to do is we're going to manage these folks' airway if it's an upper GI bleed, because we don't want them to aspirate blood. That's a big issue. So they get emergent airway management. Obviously, we're going to keep the head of the bed elevated. If we lay them flat, they're going to vomit and gurgle. Okay. The other issue is when you intubate somebody or you put somebody on BiPAP that is hypotensive, what happens to their blood pressure on a good day? It drops. Remember, you go from negative pressure ventilation to positive pressure. So anybody that you put on a ventilator, that you BiPAP, that you Cpap, you're going to drop their blood pressure. And if they're already volume down and hypotensive, they're going to have a bad outcome if you're not careful. So these folks, sometimes we use our push dose epi that you can use in the field now. The other thing that we're going to do is we're going to make sure we are aggressively fluid resuscitating this person. So he will get 2 or 3 liters of fluid with the albumin, and he'll get 3 or 4 units of blood. And then I'm gonna get them intubated, because if I put them on positive pressure ventilation without volume resuscitation or without push dose epi or something like that, they're gonna crump on you. If they're on blood thinners, we can give them something called PCC that reverses Xarelto or Coumadin, reverses it in like 20 minutes. Could save a life. Vitamin K sometimes as well. A lot of times we give them platelets, because remember, platelets help with clotting, and these liver folks have jacked up platelets because they're anemic. And then fresh frozen plasma. The good news is that blood and FFP, you guys can get as an advanced practice program. The state says you can do that. Fairly easy to use, not super expensive. Once we get the airway, we can do endoscopy, put a tube down there. If it's a lower GI bleed, sometimes you'll see them go in with surgery and take part of that colon out, and that will fix the bleeding. Sometimes we do gastric surgery and take part of that ulcer out. One of the bigger things we're doing now at the academic centers is we're doing a CAT scan with an angiogram and IR. So we, almost like a heart cath, put a catheter in there, run the wire up, we find the vessel that's bleeding and burn it or coil it and stop the bleeding. So it's pretty cool. A lot of things we can do now. Roll Tide. So we kind of touched on ketamine earlier, ketamine and heart attacks. Ketamine is a great drug. I'm very pleased that the state allowed us to get it for pre-hospital use. There are still some hospitals in the state when I moonlight that I can't get ketamine as an ER doc. So I'll have to leave the ER, go to pharmacy, show my badge, smile, get the ketamine, go back into the ER. It's still a very well-controlled drug in hospitals. I say that so you understand we're lucky that we got it. Did y'all see the news about Colorado's laws and issues? Yeah. So the point of that is we got to be safe with ketamine. So obviously, if we use ketamine on a patient, that patient has to go to a hospital. There's no giving someone ketamine and then going to jail. Bad things happen with that. That doesn't mean we cannot assist law enforcement with an excited, delirium, or agitated patient, just like they assist us. But once a patient gets ketamine, they're a medical patient, they're high risk, they go to a hospital, not to a jail. The other thing I would, yes, sir. Yes, sir. Right. Yeah. Yeah. You know, and our dosage here is still a little bit high too. But I think the good thing about that is if there have been kids who have got like 20 mgs per kilo of ketamine, which is way too much, right? And the only adverse event was they quit breathing, but it wasn't an adverse event because someone recognized it and managed that airway. So the only bad thing with ketamine is you don't manage the airway, people die. But we as pre-hospital folks, the medics, the EMTs, even the advanced, should be able to manage this airway and prevent death, right? The thing that bites you is when you get complacent. When you give that guy that's butt naked pole dancing on the corner of the interstate, right? All right, you give him ketamine, all right, he calms down, you throw him the stretcher, and you go to the hospital, you don't do anything else. That's when a bad outcome happens, right? Post-ketamine patients are critical patients. Once they get sedated enough to evaluate them, you expose them, you look for reasons they were acting goofy, you look for holes, okay? You look for insulin pumps, medicine pumps, you get an AccuCheck, you get them with a monitor, you get a set of vital signs, right? You look for things that can kill people. If you have capnography, you put nasal capnography on them. If you don't, do a sat probe. And then if they desat, so you give a guy 4 mg per kilogram of ketamine because he's agitated, acting out. Now he's in the back of the rescue. He's tachycardic, blood pressure's fine, head to the hospital, and now his sats go from 98% to 82%. What's the first thing you do for this guy? Oh, praise God. Thank you, sir. Yeah, right. Yeah, you don't put O2 on him, right? It's a ventilation issue, right? Ketamine doesn't make you hypoxic. It makes you not breathe, which makes you hypoxic. So when they get hypoxic, you open the airway, jaw thrust, maybe a nasal trumpet. If that works, stats go up, great. High five your partner, keep going. If that doesn't work, pull out your ambu bag, put the mask on, hook it up to O2, and ventilate. If you give somebody ketamine and they need oxygen, they need to be ventilated, either BVM or an ET tube. If you give somebody ketamine and they go apneic and you intubate them, you will not get in trouble. That's what you're supposed to do. That's what you're trained to do. If you give someone ketamine and they go apneic and you don't recognize it and you put a non-rebreather on them, that's when bad things happen. And I can show you cases after cases where that happens. Cool. The other thing about ketamine is it's in our protocols for altered mental status. To clarify, it's not for altered mental status. It's for the excited delirium, the agitated, the guy that makes you nervous, that's spitting at you, fixing to kill you. All right? The 84-year-old at the nursing home with a fever that's growling at you and trying to scratch you does not need ketamine. Okay? If you give them ketamine, bad things happen to them. For excited delirium, I think it's very reasonable. Yes, sir. I sure do. Yep. With the caveat that post-ketamine, then you look for a reason what's going on. But yeah, so ketamine's quick on, it's quick off. I think the dosing issue, one of the things that we talk about with dosing is ketamine should be based on ideal body weight. That's something that was never taught in paramedic curriculums. So there's an ideal body weight and there's an Alabama body weight. So ideal body weight is based upon your height for the most part. So these two guys here get different doses of ketamine. This guy gets the same dose. All right, and I'm not going to go into deep physiology of it because I forget it and get confused too. But the short version is ketamine should be based upon the height. So what I tell folks that I work with is one of two things. One, well, I guess one of three things. One, have a way to calculate ideal body weight. There are a lot of formulas out there, but I can tell you, for me personally, at 2 in the morning, there's no way I'm doing this math. It's not gonna happen. So I know what dose of ketamine I would get if I was acting a fool, right? So now I can go up to a patient, I can look at him and say, okay, he's a few inches taller than me, so he's 6'2". So I know what dose he would get based upon what dose I would get. And that way I know it's ideal body weight. And it's height-based, not width-based, okay? The other thing I say is if you don't want to do that, don't do 4 mg per kilogram on the excited delirium, cut it in half. Do 2 mg per kilogram. That way you know you're not going to overdose it. And the goal of the ketamine is not to sedate them and make them drool. The goal is to get them manageable so nobody gets hurt and you get them to the hospital.
Foreman got on there and told me that we shouldn't use it unless we're going to knock them out.
Yes, sir. Well, you're going to, again, you're going to get opinions from everybody, sir. You know, it's kind of like the old joke, you know, you got two docs in a room and you ask them a question about the patient, their opinion, and you get like 4 opinions, right? So same thing. So I think the goal of this is to make sure that we can safely manage these patients without them getting hurt and us getting hurt, okay? If it takes 4 mg per kilo of ketamine, so be it, as long as you manage the airway. If 2 mgs does it, that's fine, okay? And it just depends. There have been times I'll give them bigger doses. So not long ago, I had a patient that came in on a backboard sandwich. Remember those? You can't do those anymore, right? That's where the guy, he's, you know, well over 6 foot, big dude, butt naked, and they got him prone on the backboard and another backboard on top, and they got handcuffs holding it together. You really can't do that anymore, right? All right. So that guy made me uncomfortable. So he got a little extra ketamine, right? All right. But as soon as he got the ketamine, cuffs are coming off, backboard comes off the top. I roll him over. I'm opening the airway. And now I determine, does he need an advanced airway? Do I need to intubate the guy? Or is he going to chillax and be okay? If he chillaxes, I raise his head up. I gently restrain him. And I look for reasons for him to be excited. Right? I get an AccuCheck. I'm looking for holes on him, gunshot wounds, issues. I'm looking for patches, drug patches. I'm looking for cool tattoos, right? I'm looking for reasons for him to be so excited. Sweet. So I got a guy that's 5'6", he's 300 pounds. That's about 160 kilos. If I did 4 mgs per kilo on this dude, how much is that? I got it somewhere. Yeah, 640 milligrams of ketamine. That is a big freaking dose of ketamine. Most folks don't need that. Or if they do, they need plastic in their mouth afterwards. If I did ideal body weight on that guy, it's 5'6", he's 64 kilograms, so he gets 256. And obviously, I'm not going to do 256. I'm going to guesstimate 250, 270, something like that, right? All right. But my point is, that's about half of that. So just be wise in your dosages. If I was king for the day, I would say you max out on ketamine at 400 milligrams. I'm not. There's no max dose. But I would say if you got to pop up on 2 vials of ketamine to sedate somebody, think about it. You probably don't need two vials. Most important thing is, again, post-ketamine, assess your patient. They get hypoxic. They get airway management, not just O2. But I think ketamine is fantastic for excited delirium. Excited delirium, there's some folks at some organizations, even the American Medical Association is saying that we shouldn't use the term excited delirium. It's kind of controversial, but basically what it is you have someone who is altered, aggressive, and agitated, and sometimes even superhuman strength. When I think about these folks, I think about a couple things. I think about, do they do some meth, all right? Or is there some spice going on, or bath salts, right? The other thing I think about, do they have underlying mental disease, and now they're acutely psychotic? It's the schizophrenic who's off his medications, or schizophrenic off his meds who just smoked some meth and did some cocaine, right? Those guys get pretty agitated. Ketamine works well. You can think of other things that can cause this. Hypoglycemia can cause this, but with hypoglycemia, it's usually self-limited, right? They're hypoglycemic, they get aggressive, they get combative. Like 5 minutes later, they pass out, right? And you can fix that. Pretty easy to do, all right? So drug-induced or mental illness are the 2 big things that I think about. So it just depends. So ketamine, they chillax, and then 20 minutes later they start waking up and having a bad trip. They're agitated. I'll give them a little bit of a benzo. I don't do Valium. I don't like Valium. It's just hard to give IV. So a little Versed is reasonable, or if you have Ativan, that's reasonable. Again, the only big risk is airway compromise post that. So there's nothing wrong with that. And there's sometimes that if I'm got a patient that I know has underlying mental disease, instead of using ketamine, I'll still go back and use Haldol because that fixed the underlying problem. It just takes longer to work. And it's all case dependent, right? So if there's 6 firemen and 2 cops fighting this guy, he needs something quick before somebody gets hurt, right? So he gets the ketamine. If I got a guy that we can hold down for a second and give the Haldol and then back away and give him 15 minutes, I'll do the Haldol. Okay, there's not a one fix for everybody.
You have to call for orders.
Yeah. So my hope is that's why I said when we have our next SMEC meeting at the conference in November, it'd be nice to have a crowd there so we can discuss some of these things. I think a lot of things should be category A. is like, why is pacing not category A?
What is it?
Yes, sir. I agree. Right. So ketamine, you don't have to call orders for, right? So it's Cat A. To restrain somebody, you got to call though, right? And usually post ketamine, you're gonna have to restrain them. I agree. There are a lot of things we got to work on, and I think as an association, you guys have some good pull, and we can kind of address some of those things. Ketamine for pain. Again, the opinions with the doctors. Again, I'm not a big ketamine guy for pain. I like the thought of the trauma stuff. My only concern about using ketamine for pain is, one, you got to dose it on ideal body weight. You give somebody 25 of ketamine that is small, and now you got a trauma patient who now has lost their airway. So that could be bad because now they're probably volume down because of their trauma. And now I got to intubate them and do positive pressure ventilation. You can start a cycle that can make things bad. So just be careful using ketamine for pain. Make sure you're doing the right dose. The other thing is, in the academic place that I work, if somebody gets a little bit of ketamine and now they're kind of tripping, you know, and they show up in the trauma bay and they have injuries and they're tripping, they usually buy an ET tube to get scanned because we think they have a head injury. And like, oh, they didn't have a head injury, they just got ketamine, right? So we already talked about that. I had this slide up earlier. We got a couple of minutes, any questions? And then when you think, I wanted to kind of, a couple of things here. I mentioned the STMs, things that matter. And then the other portion, like, you know, don't forget physiology or pharmacology when you give medicine. So like nitro, a lot of people talk about nitro, that you can't give nitroglycerin to somebody who's having a right-sided MI, a right ventricular infarct or inferior MI, because you can drop the blood pressure and drop the preload. And that's true, you can. But if somebody's having a big STEMI, they're having chest pain, EKGs concerning, and their blood pressure is 160/90, they can tolerate nitro, right? Now I'm gonna put an IV in them first. I'm gonna have IV fluids ready to correct that hypotension if it shows, but they still get nitro from me. We've already talked about oxygen, kind of mentioned Benadryl and Zofran. Is there any risk to giving somebody D50? What's the risk of D50? So yeah, potentially, yeah. I think my point to this is I go places and I hear people talk about, well, hey doc, we had this patient who had a glucose that read low. We couldn't get an IV. We don't carry glucagon. There's nothing we could do. Or worst case is I heard somebody say that they can give glucose D50 rectally. And my advice is stay away from that orifice in the field. There's no reason to go there. And people are still concerned about using IOs and giving D50 in this state. And I know there were some issues years ago, but I would argue that hypoglycemia will kill people if not treated correctly. Now, if the patient is talking to you and acting bizarre, they're not dying right now. Try some oral, do what you got to do, right? But if they're altered, obtunded, and their glucose reads low and you can't get IV access, they can get an IO. You can give D50 through an IO. Now, if you got somebody that you run on 3 times a week for low blood sugar and you're disgruntled with them and you drill them 3 times a week because you don't like them, now that's wrong. But if they're hypoglycemic, they're altered, you can't get IV access, you may have to drill them and give them D50. And when they wake up, they're not going to like you, and that's okay. But people can die from that, all right? And if there are issues with that with the state, let me know. I'm happy to talk with them as well. There's no rule that the state says that you can't use D50 through an IO. There is a common sense rule that says you can't just drill people just to drill them. But if they need IV access, they need D50, there's really no risk. All right, I'd say don't give it rectally. Don't give it IM, right? But otherwise, it's really pretty safe to give. There are a lot of people talking about if you give somebody a whole amp of D50, the blood sugar goes from 12 to 300, and that is bad. And that's bad over the course of years, those ups and downs. One up and one down is not going to hurt somebody. If you want to give half an amp and recheck, that's fine. I don't have a problem with that. But don't be concerned to give somebody D50. The other thing is, do y'all even have D50 right now? Okay, because there's been a shortage, and sometimes we got D10. We just give somebody 250 cc's of D10 instead. Yeah, cool. All right, questions, comments, statements within reason?
Hey, Doc, got a couple of questions that came in.
Yes, sir.
So one, I think that you already addressed, but we have a group of questions asking, when would we use benzos instead of ketamine for excited delirium? I think you mostly addressed that. It's just a case by case.
Yeah, it's case by case. I think, the good thing about ketamine is there's limited risk except for airway, and it's Cat A. If you were to give somebody Versed, you got to call for that, right? So that's the limiting factor that I would see. Now, if Versed was Cat A, then we could talk about it and talk about different things that would help you. Remember, people who use benzos, Xanax or Ativan, people who are drink alcohol, have alcoholism, they're going to be resistant to benzo. So it takes a higher dose of Versed than you would think about to sedate someone. So ketamine would work easier on those folks. People who are combative and they had just had a seizure, and your mind's thinking, okay, maybe they have excited delirium because they just had a seizure, then a benzo would be great because that would decrease the seizure threshold and make them sedate. So it's just a case by case kind of situation. Both of them, the risk will be airway compromise.
So the other question is about expanded scope for EMTs, and so what would be the harm in Zofran, for example? Zofran we're letting advanced EMTs give, right? What about expanding that to oral Zofran for EMTs?
Yeah, I don't see a risk in that. That'll be something that have to be brought up with the state, but I don't see a big risk for that. I really don't. So there's limited risk for Zofran except for long QT, and I talk about it a lot because it's there, but it's not a common occurrence.
Yeah.
So I don't get an EKG on everybody I give Zofran to. Now, if I have somebody that has a reason to have a long QT, so an alcoholic who's malnourished, somebody with chronic health problems, somebody on cardiac drugs, then I get an EKG on those folks. But everybody else really doesn't need one. So that seems reasonable. And, we talked at the last class about potentially having racemic epinephrine moving toward the advanced level as well, something we can discuss at SMEC. But again, that would have to be brought up at the SMEC committee and has to be approved by everyone. I'm not in charge of that.
Yeah, I think that's where those questions are headed, because you're talking about Benadryl and Zofran,
Yeah.
where people are using it without the ability to analyze the EKG.
So my advice would be that if there's these things that you need, that is a group y'all want changed, take it to your regional MDAC meeting, and your regional medical director should be addressing those and moving that toward the SMEC committee. The other option would be there's a EMT association, there's a fire college or fire service organization representative for SMEC, if I'm not mistaken, and those are things that y'all can take to those people as well to address at SMEC. And I'm happy to help with that as long as there's backing from those organizations and you guys. I don't mind doing that either. So.
Very good. So, hey, everybody online, if you haven't already, please remember to click the link in the chat box and fill out your form. If you can't do that for whatever reason, you can send a email to Alabama EMS Challenge at gmail.com, and that'll get you an automated reply email with a link to the form. So please, everybody, fill out a form. It's come to our attention lately that there's a lot of people who watch and don't fill out the form because they don't need the CEUs. Please fill out the form anyway so that we can count your attendance and we can get your feedback. Please be honest on the feedback. We do look at the feedback, and we take action based on what people tell us. So we really appreciate your participation.
Yeah.
Thanks, everybody, and see you in 2 weeks,
Yeah.
right?
Any questions, guys? Oh, more questions. I like questions.
Benzos, so we have Narcan.
Yes, sir.
What's the?
So Romazicon, yeah. So I'm not a big fan of Romazicon. In theory, if you give someone Romazicon, you're going to block all those GABA receptors, and they wake up from the benzo. But if they're an alcoholic or if they're a benzo dependent, there's a chance you could put them in seizures theoretically. So we don't use Romazicon in the ER training that we do for our docs. Romazicon is a drug that we just put a big X by. We never use it because the Romazicon reverses the respiratory problems with the benzo, and we can fix that with plastic or a tube. You don't see a lot of hypotension with benzo overdoses. So, we can fix it with a plastic intubation. If they're still hypotensive, we can give them a little bit of pressors. So they're just too much of a risk. If they started seizing, nothing you can give them. You can give them like an anti-seizure drug like Dilantin or Keppra, but that doesn't work quickly. And then if you fry their brain because they seize for 20 minutes, you just hose somebody. So.
Is it sustainable for what you said? You said a while ago, if you give ketamine, you got a patient.
Yes, sir.
So dealing with awful sometimes is like hard,
Yes, sir.
and it's a big topic right now, of course.
Yes, sir.
If you give ketamine, my members, that's a patient that's going to the hospital. This is not a patient, hey, now we're going back to the quad car, that's jail.
Right.
Correct?
Yes, sir. I agree 100%. No. Because a couple of reasons. One, you just gave a pretty significant drug that we can't give in the hospital sometimes as docs. And two, there's a big risk for a bad outcome, and you don't want that. One, because it's the wrong thing to do, and two, you don't want to be in the news. Yes, sir.
Hey, we'll do this, but we're going to the hospital.
Right. This patient, he's a patient now. Yes.
I think somebody down put back in the cell.
Correct.
Just cause we get in trouble.
Oh, no, sir. Like if you show up at the jail and you give ketamine, they go to the hospital. Yes, sir.
You do get asked to do that.
Yes, sir. Yeah. And I would say no.
Yes.
Right.
Yeah, the other thing that happens on that issue is you got to make sure you tell the receiving hospital staff that you gave them ketamine, because that patient needs to be continuously monitored post-ketamine.
Yeah. 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 And again, yeah. And again, like I said, there's some hospitals that, yeah, there's some hospitals that don't even use ketamine at all. The nurses, the docs don't. So you got to let them know what's going on.
Ours didn't make it started.
Yes, sir. Yeah. Well, it doesn't matter. I mean, it is what it is. It's there for us. We can use it.
We like it, because it works.
Yes, sir.
And the state, at our doses, it's been very effective in that short-term
Right.
pain relief. And usually by the time they get on to the hospital, they're out of it,
Right.
you know, where they can answer questions correctly.
I agree. So do y'all carry other pain medicines or just ketamine? Y'all carry fentanyl as well or morphine? Okay. Okay.
But start with, it was just getting,
Okay. Yes, sir.
it is the medical patient.
Yeah.
You can no longer assess that patient,
Yeah. Yeah.
other than what you can see.
Right.
What's your opinion? I know you want IV access prior to giving ketamine, if you don't, if you IM, but do you prefer IM or IV?
I would do IM. So I got no problem with IM ketamine for excited delirium. So if the guy's, fighting folks, yeah, IM ketamine. But once he gets chillaxed, that's when you expose him. You got time to start IV, get an active check, put him on the monitor, and go from there. I would argue that if you have to give somebody IV ketamine, the first dose for excited delirium, they probably weren't in excited delirium. Yeah, yeah. Now, if you have to give some IM ketamine for pain, so you got a guy in trap, the femur fracture or something, you take a few minutes to get him out, and then, you give him, 20 milligrams of ketamine IM or something, and then you get him out and then start IV, that's reasonable too. So,
That's pretty much the place. This is a pain IV drug, so.
yes, sir.
Right.
All right. Good, Chief.
Yeah, I think so.
All right.
Thanks again for everybody that joined us online and everybody that joined us in person. Remember to do your attendance form. We appreciate Troy Fire Department hosting us today. And as always, we appreciate the Alabama Fire College for sponsoring us. And we'll see you again in about 2 weeks. Is that right?
Skills Lab, 12:30 here at Troy, if you're in the area.
Yeah, if you're in the area, come by Hawkins Hall. We're going to be in, I think it's room 119. Is that right, Chief? Yep, room 119. We're going to be doing some pit crew CPR, some scenarios with high fidelity mannequins, surgical airway, difficult airway practice, and we'll be starting at about 12:30. So thanks, everybody. We'll see you next time.